very excited to have him here. He leads the IT team at Ochsner that was responsible for the HealthKit and Epic integration. They were the first healthcare system to do so. I remember when Apple first announced HealthKit, they announced some partners.
We were not one of them.
Yes, exactly. And then not long after that, I saw news that they were the first to actually do the integration. So I feel pretty lucky to be able to learn from some of what they've been able to do, because they really are ahead of everyone else on what they're doing. And it's not just about the integration itself, but what that integration has enabled over at Ochsner. So he's going to describe some of that, and thanks, Jonathan.
Thank you. So as she said, we were the first to do the HealthKit integration. We were not one of the beta sites. Stanford, Duke, some other places were that. But we kind of broke into the scene last year. We developed our Center for Innovation last year. We are tasked with going kind of above and beyond what a lot of health systems do, which is just kind of incrementally optimize their system, just kind of every year do something different. We're trying to like radically change the way we are treating our patients at Ochsner, and we felt it took kind of a different team to get out of the grind of everyday optimization and maintenance and kind of go for the gold and try to actually affect the way we're treating our patients overall and tackle core business problems, and with the goal of scaling them system-wide. So not just grabbing kind of the latest and greatest technology that's in the news and do something and get a press release and move on with it. We're focused on making real changes for Ochsner and for our patients in the area. So we were in the news last year for doing HealthKit, and yes, it is kind of flashy, like we get in there, we're implementing an Apple product, but I feel like this was chosen with a very specific goal in mind, and I'll be getting to our hypertension project in a little bit, but this really does connect patients from home into the clinic, and it was a very important goal for us, and it was perfectly timed with our design process for our hypertension project. So when we found out about it, Dr. Milani, our Chief Clinical Transformation Officer, was talking to Apple. They're like, oh yeah, HealthKit's coming out next week. And we really didn't know too much. We're like, okay, we'll do it. And then a week later, we did it. So it was kind of a spur-of-the-moment thing, but it went really well. We got a lot of attention, and we get a lot of invites back to Apple and Silicon Valley with just how quickly we do our stuff. Last week, we announced Innovation Ochsner, a new company that we just formed. It's kind of our way to partner with businesses, both locally and nationally, to help develop products and technologies together. You know, have Ochsner be a place where you can pilot and implement your technologies, partner with us on the business side to also roll out to other places. More of just like just an accelerator for different technologies and different programs in the area. We also have a National Innovation Challenge partnered with GE Healthcare. It's focused around wearables, not a lot of details. It does open up this summer, and there'll be more information about that too. So before I kind of get into how we're innovating at Ochsner and how we're, our focus for chronic disease management and some other topics, I kind of wanted to go through what the IT, how the IT prepares for innovation and prepares for our enhancements. And it's not something that people talk about, but at Ochsner we have a very focused approach to implementing and rolling out all of our clinical systems. And so it's kind of a pyramid, and it's really simple, but you can't really do much. You can't do it quickly if you have a really poor foundation software system. So Epic is our hub right now. It's our hub EHR, and we're rolling out to all of our hospitals across the state and a lot of our partners. So we make sure we have system-wide standards, and everybody's doing the same thing in every hospital. That gets us to the point where we can optimize quickly and be very agile with our new projects. So if you're busy in the weeds trying to maintain 15 different systems at 15 different hospitals, you're never going to do anything new, because you're going to have a really large team just to kind of stay afloat, and you're just going to drown in your work, and you're never going to do anything cool. So we have a very, very specific goal at Ochsner to have system-wide standards. And with that, we can have speed and flexibility with new projects, and then ultimately our end goal is to innovate and change our care delivery models. So all of our decisions are pretty much based off of, is this good for the system? Is this going to be system-wide? And will this allow us to be quick and flexible in the future? And if it's not, we're not going to do it. Epic is our hub system, and we say that integration trumps best of breed. So we have a lot of different clinical systems, but if it can't integrate with our hub system, which we've chosen Epic, it's not going to really have a chance in our organization. Everybody uses Epic. So if we have other systems, it needs to seamlessly integrate with Epic, and that's a very key point for how we do our business in the IT department. We're not going to add on 15 different add-ons and 15 different facilities, because we're slowly going to get bogged down in maintenance, and we're not going to be able to get to where we want to go, which is actually change the way that we treat our patients. We also think that if Epic can do it and it's good enough, we're going to use Epic. So we're only going to go outside of the Epic family if they can't do it or they can't do it well. And Epic was down here this week meeting with our executives and actually said that we are actually the best Epic customer in the nation when it comes to utilizing their functionality the appropriate way. So we're really proud that we use Epic, which we think is the best EMR in the world, and we use it better than anybody else in the nation, and we really stick to our guiding principles, which is system-wide standards. Everybody uses the same workflow, so we can actually change really quickly and innovate. And it's not something that people talk about very much. A lot of people talk about the cool stuff they're doing over here and over there, but we're very proud of how we keep our core functionality standardized so that we can move fast when we need to. So the Center for Innovation was created last year, and we needed to choose a topic. We don't have that many resources. We're growing. A lot of our funding comes from just our operating budget and our IT department, but we are getting a lot of donations and grants coming in. But we said, what's the biggest need for the healthcare industry and for Ochsner right now? So where do we begin? So we think about necessity is the mother of invention and hopefully innovation too, so we start looking around the industry. The United States spends a lot of money in healthcare, and it'd be okay if we were way better than everybody else in treating our patients, but we're actually kind of last in a lot of our quality indicators, so we're spending the most and doing the worst, so there's kind of a big problem there. We're running out of physicians. The supply is not keeping up with the demand, so that's another big problem. Talking about major epidemics in history, bubonic plague in the 14th century killed 25 million people, cholera in the 19th century, 50 million people, influenza, 20th century, 75 million people, and today 50% of the population and 75% of all deaths come from something, and it's actually chronic disease. So it's kind of like a modern day epidemic right now that doesn't get too much play on number of deaths, but it's actually 75% of all deaths in the country right now are chronic diseases. Medium outpatient visits, there's only 15 minutes over 6 topics, so we have a lot of sick people, we're not spending a lot of time with them. And to kind of play off the epidemics side, the 4 health behaviors that go into chronic diseases, lack of physical activity, poor nutrition, tobacco use, excessive alcohol consumption, have actually shown to be infectious among social networks. So it's not an infectious disease, but the behaviors that kind of go into chronic disease is infectious, and a lot of new research is showing this. And over time, it's only going to get worse. Dr. Milani, our Chief Clinical Transformation Officer, says, this is a stock you should buy right now. It's only going to get worse. Are we treating our patients appropriately? Not really. Out of all of our chronic diseases, only 55% of our patients are receiving the recommended care, which is also seems like a big problem. So I think I've really hit this home. What's the necessity here? We're spending too much. We're not doing well. Our demand for physicians is outpacing our supply. Chronic disease is a modern day epidemic. Only half of our patients are receiving recommended care. But what's this last part? Before I get there, I kind of want to go into factors influencing a patient's overall health. So certain parts of this you can't really help. Genetic predisposition and environmental exposure making up about 35% of these influencing factors. You don't have much control over, but you think in the healthcare industry we're going to really help, and 40% of a patient's overall health status should be from the healthcare they receive. But it's not, it's 10%. So we go and we do a lot of projects and try really hard to treat these patients, but it's only about 10% of these influencing factors. So what makes up the other 65%? It's actually social circumstances, so their living conditions, their access to transportation and care, can they afford their medication, what does their social network support group look like, what's their education level, and actually the biggest chunk is just behavioral patterns. So depression, just taking the medications that we're telling you to take and you can afford to take, are you even taking them? Just tackling that alone has been estimated to maybe solve about half of our, to take care of about half the cost of chronic disease management alone is just medication adherence. Solving that problem would be huge. But your social network influences everything that you do. Those are kind of like those behaviors in your social network are infectious too. Lifestyle, patient activation, these are actually the major factors that are going into a patient's health, and we aren't necessarily trained or even addressing a lot of these issues right now. So when the Center for Innovation thinks that, what are we going to focus on this year? I think it's these points, and it's going to be chronic disease management, focusing on the right things, decreasing cost, using people other than physicians, and actually targeting behavioral issues. So last year, this year, chronic disease management, focus on the behavioral, the social influences, prioritizing these for our department, starting off with inpatient readmissions, what's the percentage of patients coming back in within 30 days of an inpatient stay, and heart failure, 1 out of 4 people are coming back, it's the most. So in the inpatient world, we're focusing on heart failure. In the outpatient world, hypertension, about 1 in 4 visits have hypertension coded. So these, we don't have a large team, we don't have a lot of things to work with, but these are 2 very huge needs for Ochsner and the health industry, and these are the 2 that we decided to focus on. And we'll go into a heart failure program and a hypertension program, and then into some wearable stuff. So first, heart failure. We decided in the inpatient world, we're kind of going to have a targeted focus on what the patient really needs right then and there, and then an outpatient focus for those 30 days with some telemedicine. So in the inpatient world, we're going to have detailed, targeted assessments. So we're going to calculate a readmission risk and a mortality score by the physicians to enroll them in the program, and then we're going to evaluate all those different social influences and behavioral patterns that might go into why they're readmitted. So we assess affordability of meds, medication adherence, depression, transportation issues, try to flesh out all of these issues in advance of them even leaving. We do it with tablets, so we're trying to take some of this work off of our nurses and physicians by giving tablets to these patients. They go through these assessments. It's kind of a guided questionnaire. If you score too high on your SALT questionnaire, you watch a 10-minute video. If you don't actually prepare the food and the meals in your household, it's going to ask you who does, and then hopefully they can watch the video with you, and we'll email those videos. So we're trying to target these areas in the hospital stay and get consults before you leave. If you're depressed, see a psychiatrist. If you're not eating well, see dietary. If you can't afford your meds, see a pharmacist. Leave with a 30-day supply of your medication rather than going home with nothing and just, not taking any heart failure drugs. So it seems kind of easy, but it's not. We weren't really doing this beforehand. And especially on the outpatient side, we weren't really following up with the patient. So taking your weight every day is a good indicator of fluid accumulation. So we give our patients a Wi-Fi scale with a Wi-Fi card, and it's all linked up, and we register it to you in our EMR, and all you have to do every morning is stand on it, and we get it electronically right inside of our Epic EMR. And we have pharmacists sitting there waiting. They have, 50 patients on their queue. They log in every morning. They watch the weights come in. And if one is too high, they're going to call and they're going to intervene before anything can happen. So did this work? Yeah, it did work really, really well. Our pilot program at our Jeff Highway campus actually halved our readmission rates. And the most impressive number not on here is our 30-day mortality rate decreased 90%. So it was pretty amazing just to see how targeting different things that we usually didn't, some behavioral and social factors, really did affect that patient's health over the next 30 days and dropped our readmissions by half, mortality by 90%. So we went one step further with hypertension. This is where kind of HealthKit came into play too, because they're not in the hospital. We're just asking patients to do long-term chronic disease management at home.
How large was that group with the 90% improvement?
How large is the group? Our pilot has done maybe 200 to 300 people. We're expanding. That was a pilot at our Jeff Highway campus. We just expanded to every patient, so we're no longer piloting, and we're actually working with our other campuses. So we're hoping to get 2,000 patients a year on this rather than 200 to 300. So it was a good number of patients, but we're not even touching a lot of our other campuses and people that are coming in with heart failure. Yep. So hypertension, 40% of patients or of adults in Louisiana have hypertension, which is kind of the worst of the worst. So we feel like anything we can take a dent in here, in this area, is going to have pretty much dramatic effect elsewhere in the country. So for hypertension, just like banking can be done outside of a bank, in the 90s you go to the bank, now nobody goes to the bank. We kind of feel like hypertension should operate that way. We have tools at home that can measure your blood pressure, so why do you have to come in to the office? You kind of don't. So our approach for hypertension is to move away from a traditional healthcare model, which you need to come in, so you go to the office, you see your PCP, if they can't handle you, they'll send you out to a specialist. We actually want you to come into the office only if you need to. We want to have a focus factory for every chronic disease out there. So hypertension, we have a team of hypertension experts. We have pharmacists, we have health coaches, we have behavioral therapists. And you're enrolled in that hypertension program. And we use apps on your phone. We use wireless blood pressure cuffs. We use social networks and get you involved with different local activities and have a team manage you that way rather than just kind of having in, every 6 months you come in, you get a blood pressure. Okay, you're not doing well. Come back 6 months, you're not doing well. Have a truly kind of like, every few weeks we're touching you. People are calling you and getting in touch with you, and just a constant continuum of care, which is drastically different than what our model is right now and even what we get paid for. And in 2015, Medicare actually just came out with a chronic disease management code for remote monitoring of patients. So it actually came at a really good time because we're doing this on our own dime, and now Medicare is actually going to pay for it soon. So this program has been proven through research that it can be more effective than going into the office. So telemonitoring is about 72% of patients can get into control, whereas the usual care about 50%. So research said this should work. And so right now we are focusing on hypertension, delivering these patients. We just started our pilot on the North Shore, and as I said before, we are using non-physicians. It's a focus factory. Everybody's experts on hypertension. We actually assess behavioral issues and social circumstances beforehand, treat those rather than just give you a pill, and exploit all of our technologies to the fullest. So this pilot right now, I think we've enrolled 30 patients in the last month. Our average age is 74, so it's not like we're picking all of our 30-year-old hypertensive patients. We're actually going for anybody who's out of control, anybody who's willing to get a Wi-Fi blood pressure cuff, utilize Apple HealthKit if they have iPhones. We also have a pipeline with Withings and Fitbit into our EMR. And kind of relating back to the very beginning about why we think HealthKit was super important for this is because there's a lot of different wearables manufacturers out there, a lot of different blood pressure monitors, and we can't possibly keep up with every manufacturer and integrate with every single person. And we did Withings and Fitbit, and then Apple HealthKit came around. We're thinking like, this is really good for us. Every manufacturer can integrate with Apple, and we just have one pipeline with Apple. And it kind of opened the door for us like, okay, now we can allow any single Apple HealthKit enabled Wi-Fi device, which allows more patients to join. We do have donations from around the community for people who can't afford blood pressure cuffs to kind of subsidize those, but just if we really want to get everybody in there, we didn't want to discriminate against manufacturer. And so that's why HealthKit was really important, why we made a big deal about it, and we thought it was really nice that other people thought it was pretty cool too. But it really does. It goes with our kind of our principles that we want to standardize wherever we can. So the next idea that comes out, we can respond really quickly and not be bogged down with maintaining 20 different pipelines to 20 different manufacturers. So hypertension's going well. We are targeting the behavioral and social aspects of a patient's care, and the wearables and the new technologies that we're looking at focus on these. So if anybody else has apps and has devices they're working on, our focus in the Center for Innovation is definitely new data points at home. We're talking with sleep apnea, Philips, to incorporate sleep apnea usage into our program, getting that data, getting inhaler data for COPD patients. The more data, the better. Some people talk about, and they're afraid of the data, they don't know what to do with the data. We just want more, and we'll figure out a way to do it. So if anybody's looking at that, we look for more data in more areas at home, everywhere. We want to increase patient engagement, especially within their social networks. So any type of technologies that do that, we're very interested in. Medication adherence is huge. Doesn't matter if you get prescribed meds, if you don't take them, it doesn't help. So we're really looking at medication adherence tools and apps and technologies to help with that, and a couple other stuff. So these are kind of the things that we value. New wearables that are coming out, the Apple Watch. We really think the Apple Watch has some potential, maybe not right off the bat. I don't know if any of you have heard too much of how it works, but apparently there's going to be a way when you put the watch on, you activate it with a thumbprint, and then it's enabled. And if you take it off, it disables itself. So it's one of the first ways you really know that somebody has a device on their wrist and it truly is them, which opens up like a new level of intimacy with the patient. You know who it is. You can send more meaningful communications to them without worrying about violating privacy laws. If you have a cell phone, you don't know where it is, so I can't send you really anything meaningful other than you have a new message, go check your patient portal. And then you rely on the patient to log into their computer and check their portal and see what you say. We really hope that this watch will actually allow us to send meaningful communications. The one thing we were really looking forward to around medication adherence is that we prescribe a new medication for you. You're in a hypertension program, it's not working very well, we're going to prescribe you a new drug. We will know when you pick it up from the pharmacy because we're integrating with those pharmacies, so as soon as you pick up your med, we know it. 24 hours later, we can message you on your watch, hey, did you pick up your XYZ drug? And you can't say drugs over a cell phone, but if we know you're wearing your watch, we know it's you, we can say that. Are you having any side effects? Yes or no. Respond back yes, no. Comes right back to our team. So we really think an Apple Watch could be a game changer. Not right this second because that API is not opened up to third-party developers. Only Apple has access to it. But we're working with them to enable that so health programs can actually utilize that communication back and forth. So things like this we're really excited about. It might not be April, whatever, when it comes out. We're handing them out to everybody, but when that API is opened up, that's going to be one of the first things that we look at to try to increase engagement and build a relationship with our care team. So that really gets us excited. And everybody has opportunities with this. There's a National Innovation Challenger on wearables. There'll be more information this summer, but these types of things really get us excited, and it's a way to partner with Ochsner if you have ideas and anybody else has ideas, for us to pilot your stuff and work with GE to kind of implement it and roll out. So those are some things that are exciting us right now. You always have to think about data integrity too. So this isn't something we really thought about until we started getting a lot of devices into our patients' homes. You really want to make sure it's them taking their blood pressure and not their grandchild taking their blood pressure, which can be an issue. One of the devices, actually our preferred blood pressure cuff we were going to hand out, the device itself, the blood pressure device, is linked to you. So that means if a grandchild comes around and puts it on and takes their blood pressure, it just comes over. And that's obviously not a good idea if we're making clinical decisions about this data. So data integrity is actually a very important part. We actually went, for our hypertension program, we're requiring people to have cell phones. And the Withings app, you initiate the blood pressure from your phone, and we feel like you're less likely going to hand your phone off to your child and say, yeah, go take this blood pressure, even though I know it's the wrong thing. It's just less likely we're going to have those issues. So it's something that kind of caught us by surprise we didn't really think about, that once you get into the patient's home, you really don't truly know if it is the patient taking those devices, and you have to take steps accordingly. So that's kind of a lesson learned on our part. And also, integration. So everybody uses Epic, and all these devices that people have been coming with to Ochsner, and we've been partnering with. We need them to work with our EMR. We can't have people using 15 different systems. So as people develop new solutions and new technologies, we really want those to be able to be accessible, and all the data come back into Epic. I don't know if anybody here is an app developer, but open.epic.com has all of their different APIs that you can tap into. So anything that does go on, we're really looking forward to working that back into Epic. And for people who are making, that's kind of the gold standard. If you can work with Epic, you can work with like 60% of the hospital systems in the country. So I know I went really quickly because I knew there were going to be some questions about what we were doing. So anybody have some? Sure.
Many of my clients are physicians and they're working in medical practices, not hospitals. And Epic is not a known commodity in the outpatient setting. How are you going to bridge that gap? And I hear a lot of outpatient EHR and practice management systems, and Epic isn't up at the top. It's in the list at all. It's way down.
Well, so, I mean, everybody at Ochsner, our entire health system, inpatient, outpatient, is using Epic. So our focus is clearly going to be on what Ochsner is doing first, right, and then moving out from there. So for us, because Epic is our hub, that's our focus. Right. And we do have partner practices that aren't using Epic, and they will need different solutions if we roll things out to them. But for us, I mean, our organization right now, we have 1,000 physicians up on Epic, and that is our focus.
So you mentioned obviously it's Apple integration. What about Android?
So Android, we chose Withings and Fitbit. So with Apple, it's very convenient for us. Any manufacturer can integrate with them, and we maintain that pipeline with Apple. But for the Android users, we had to choose the biggest ones, and we have Withings and Fitbit. Right now, if you're Android and you choose something other than Withings or Fitbit, we currently don't have an integration set up for that. But Withings and Fitbit, they're like the two biggest ones right now, and most of our Apple HealthKit users are using a Withings device anyway. But we had to make a tough decision, but for Android, if we went to too many people, we wouldn't be able to maintain it, so we got those two big ones for Android.
Actually, along those lines, when you talk about data integrity, what does that do to you when you're getting such a diverse set of data, different types of data from different systems, how to work from them,
It's a good question. So our at-home data is separated from our in-office data. So we don't compare those two. People talk about white coat hypertension. You're just in you're in the clinic and you're in the hospital and your blood pressure is just a little bit higher. So everything is separated out. So we do analytics, kind of the in-office stuff and the at-home stuff, and we try not to blend them up when we do averages. We are forced to do that sometimes, but we do keep that separated.
When you're outside stuff, that's where your difference lies.
Yep.
You have to really watch how you compare that data based on.
Exactly. We do more of our analytics is over averages. So we don't take any one reading and treat that like it's the truth. If your blood pressure, so in our program, if your blood pressure spikes to say 200 over 110, we're not going to immediately think there's an issue. We actually automatically text you to redo your blood pressure, and if it comes out a second time, then it triggers our pharmacist to give you a call and see what's going on, see if you need emergency care, or if something different is happening. So we don't ever take one data point and treat it as a truth. We need to validate that at least twice before we think there's an issue, and we also work mostly on averages. Because there is, like a Withings blood pressure cuff, you take it, minute apart, they could be significantly different. And also on the different arms too. So some people have different blood pressures on different arms, and they're just different. So you can't ever just take one data point. We separate it from in-office, and we do a lot of averages just so we can have a little more accuracy.
I was wondering, how do you create your risk models that you're using, and what are you using to execute those operationally?
So Dr. Milani created all of them from scratch, and we build them all inside of Epic. So all the data comes in, and we have our analytics tools compiling everything there, running through those algorithms, and we constantly tweak them. We take basically a lot of the risk models from different research papers and kind of pick and choose what we like and try to develop our own. So we do have validated risk tools. They aren't as accurate as we want, or we don't think they're actually that great, so we're just trying to improve on that. And actually for heart failure, our risk model, Dr. Maloney just actually published ours, I think a few months ago. I forget which journal it was, but we do a lot of that stuff in-house.
Can you talk a little bit about what you mean by a risk model in case for something?
So for heart failure, readmission risk is kind of a gold standard. So if you can have somebody in the hospital and you calculate a risk score of them coming back within 30 days, it's a very, very valuable tool. So Medicare will actually fine you if you have too many patients coming back within 30 days. So for our heart failure readmission risk model, most other risk models only take in kind of clinical data, and ours is actually very, very focused on behavioral issues and social circumstances. And we actually found the number one indicator for our readmissions and heart failure was social isolation. And there's many different factors to that, but you're socially isolated, you're 80 years old, you don't have anybody in the house, people might not remind you to take your medication, you might not have a car, you might not. So our question of do you live alone was actually the single biggest indicator of readmission risk, and that's why we started tailoring our risk models to different things, not just clinical data, but a lot of social and behavioral data.
So I understand these are rule-based models defined by experts versus data-driven models.
What do you mean?
Well, is there, the execution time, does Epic have an inference engine that allows these risks to be calculated on the fly?
Yep.
And is that rules-based, or is that driven by a statistical model?
Rules-based. And they also have we haven't gotten a lot of the statistical models yet. Epic does have that functionality, but ours is more rules-based, on the fly, constantly calculating. Yeah, absolutely. All the statistical-based stuff we've had to export into other systems. And the heart failure one is pretty much the only one we've done that with.
So you mentioned that this year Medicare is coming out with some sort of reimbursement for the remote monitoring, and I'm sure you guys are happy because it's probably not sustainable to be giving away.
Absolutely.
So is there currently a system in place where you're getting any sort of insurance reimbursement for these, remote devices, et cetera?
Yep.
Or
Well, we have a shared risk model, and we have a population that's capitated, so we're responsible for 100% of their care. So it makes a lot of sense for us to make sure they're healthy and they're not coming in for, these acute episodes in the hospital.
Sure.
So that right there, and that's why a lot of our patients are older, because that's our Medicare Advantage plans and stuff like that.
Sure.
So a lot of that, we have a lot of employees, we have a lot of other people, but the only thing that financially makes sense for us is those capitated patients. And we're actually looking forward to having other Medicare patients have some sort of reimbursement for that.
So I see that making sense for, like, say, the heart failure model, where they were probably an inpatient at one point, and this is kind of a continuation of care issue.
Yep.
But for kind of purely outpatient monitoring along with their hypertension, do you guys have any sort of, how does that model work, if you don't mind me asking? In terms of reimbursement, or in terms of, is that also the same system, the same capitated?
Well, it's different. So some things we do because we know we can do them really well, and we know we have a really a big chance of making a difference, whether it is financial or not.
Okay.
Hypertension is one of those guesses. Like, research shows we can control these patients better, and we do have quality metrics at a system level. All hospitals do. And the better you are, the more money you can get paid from different insurance companies. So directly having those patients in control might not net us more money, but being better doctors is always good, and having healthier patients. And so some things we just take a bet on, like, this is going to be good. Just a lot of the innovation projects right now, we don't know if they're going to work. A lot of these are just research oriented and haven't really been done that well in a real health system. And so there are a lot of guesses and a lot of jumps here, but we're confident in what we're doing, and we think that if we do a great job, the rewards would follow. And on top of just having healthier patients as well. But that is a good question. Yeah, a lot of this stuff is just kind of like, well, we're going to do this, and anybody want to donate to give out some devices? So a lot of our devices right now are subsidized. The Withings blood pressure cuffs are $130, and so we have donations right now. They're only $40 for our initial patients. So to help it make it a little more affordable.
So with kind of along the same lines, what's the next step for y'all? I mean, are they looking at diabetes? Or?
Yep, diabetes, COPD. I just read an article, I forget who it was, but they have GPS trackers on their inhalers, and you can message people about alerts and where they are, and just like a lot of new cool stuff. And diabetes is a good one, tracking glucose. A lot of HealthKit workflows with that. So we're going to kind of work our way down the line. Once we get heart failure and hypertension kind of under our belt and get it operationalized and flowing smoothly, we're going to kind of move on to diabetes and COPD. Those are probably the two biggest ones that we're going to look at next. Yeah, it's a good question.
Because medication experience is a big deal across the chronic ward, and because I worked on a solution a few years ago, I was wondering what you've got cooking for at home for that for patients.
A lot of pie-in-the-sky stuff. We're hoping the initial solution is going to be tracking with pharmacies. So we have electronic prescriptions going to the pharmacy, and we're going to be trying to get accurate data on when those are picked up, not filled. So there's a difference between a pharmacy filling it and the patient picking it up. So in real time, if I send a script to the pharmacy, they're going to fill it and mark it as filled. The patient doesn't come back and get it. A week later, they're going to unfill it. So having a lot of our real-time tools right now look at fill data is really not going to work really well to figure out if that patient picked up their script within 2 days, 3 days. So we're kind of partnering with some pharmacies to see if we can get real-time pickup dates. After the fact, with claims data, you can go back and you can see who picked up their scripts and when they did it. And we want to use the claims data to calculate trends and kind of a variance of, you have a 30-day script and you pick it up every 45 days, so we know you're at risk. And then try to work more with the pharmacies to get real-time pickup dates so that we know you said you're going to pick this up in 2 days, you didn't, or you did pick it up. Are you having any issues? Or it's been the 30-day mark, and at day 35, we know you didn't pick it up. So we're trying to look like use more interfaces directly with pharmacy's point of care system, as well as trending claims data to figure out who's at risk and then real time who's picking up those meds. Dr. Melani's been out to Silicon Valley, and there's a couple of drug companies that are developing devices that go in your pills, and you take them and the pill knows you took it. I mean, that's a couple of years out, but he's been talking with a lot of companies doing that too. So, 5-10 years out, maybe your pill itself will know that you took it.
Some pills are expensive.
Yeah. But it's just some crazy stuff, so.
What's the experience with the users been like? Does it require a lot of training? Do they start to trail off in their engagement to it? Yeah.
So like patients are end users in our system. Yeah, so patients, I would say the younger population is a breeze, and the older population is a little more challenging. They're not really savvy with their phones, and most stuff works with your smartphone, so not as many Medicare patients have smartphones, and the ones that do, it's like my daughter uses it, or it's my wife's and I use it. So I would say our biggest struggle is just teaching them technology. Putting on the cuff and initiating is kind of simple enough, but if there's ever an issue, it takes a lot of, over the phone troubleshooting, and sometimes it doesn't even work, and they have to come in to our clinics, and in our primary care building we have a new O bar, like kind of our technology bar, Genius bar, and that's actually worked out really well, 8 to 5 Monday through Friday. So they get help there, but in places we don't have an O bar, it's a lot of over the phone support, and it's actually very time consuming.
Right. But you said something about sort of reminder or checking in on them. And I think we all worry about this, that just constant flood of information, one more ding, one more, the joke with Apple Watch, you always have mail.
Yep.
And so I just was wondering if you had seen anything where you were like, 3 weeks into it's like, I don't want to do that again.
Right. I guess it's all about how well our technology is going to work. Our device manufacturers go down a lot. So you wouldn't think about, you get a blood pressure cuff and it goes off and it goes to Ochsner. Those manufacturers have downtimes all the time. So we're very sensitive to sending people communications like, hey, you forgot to take your blood pressure, when they did, and it's just because these manufacturers are down. We just had an issue this week. We asked like 5 people, like, hey, you forgot to do it this week, and they're like, we did it, and it just turned out why things was down for the day. So we are learning from experience, and we're trying not to communicate too much with those patients when it's unnecessary. We won't tell you forgot to take your blood pressure for at least 8 days, just to make sure that you might be out of town, you might be doing this. But yeah, it actually is a very sensitive subject, and we don't want to cross that boundary of what becomes nice and what is just a burden to keep getting communicated.
Your concerns with patient access to internet connectivity regularly?
Yes.
You do it on the phone, I mean that's cellular, but it's hit or miss. Is that a problem?
Yep. So that's why we went kind of cellular based too. Home internet might be common nationwide, but once you kind of get outside of New Orleans, it's not as common, especially with the older patient population. So I think one of the biggest challenges with getting devices in patients' home is definitely connectivity. Reliable connectivity too. Our heart failure program uses cellular for our scales, and it only works in probably 85% of the households we give it to. And that's when we rely on calls every day and just stand on it, give me the weight. Maybe a couple a week are going to do it. But for those 30-day programs, it's not that intrusive to call them every day because they're at a very high risk of coming in. But definitely for long-term management programs like hypertension, you definitely don't want to over-communicate because it can be just a burden for them. But we're only 30 days in, so we haven't really probably approached that boundary yet, but it's definitely something we're aware of and we have to make sure we're careful with. That's a very good question.
How do you handle the pairing of sensors? So if you have a blood pressure device or weight scale, how do you pair it with the application in the smartphone?
It's actually done through our patient portal. So everybody in our programs are required to have a My Ochsner account. So you can go online, and on that patient portal, you can pair your Withings or a Fitbit device. And then Apple you can do on your cell phone.
So the expectation is that the patient goes and buys the device on a retail store?
They can.
They log in?
Yep.
themselves, or do you guys?
If they're capable. So on the South Shore, we have our O-Bar at our Jeff Highway campus. So if they need help, they just pop right in. They can buy a device there, and then our representative can actually help them sign up for MyChart if they're not, log into MyChart, do the device pairing, and then get training on it. A couple of our employees that have been in there, they just bought it themselves and logged in and did it, and it was perfectly fine. So it's all about whether they're capable, and we have support models for both. So
in your high-risk patients, and you do this risk stratification while they're inpatient, you identify somebody that needs to be monitored. When you're going to discharge them, does someone come in and hands them the tools?
Mm-hmm. So
you charge them for those tools? Or?
For heart failure, we ask that you return them. We beg you that you return them because we want to give them to other people. But for the 30-day readmission programs, we're kind of like handling those as hospital property, and we'll give them out to you in the hospital or have home health bring them around and set it up for you. For hypertension, since it's a multi-year type of thing, it's got to be a little more hands-off because we want more volume, and it's for a longer period of time. And that's patient-owned devices. So there's kind of a difference. 30-day readmission programs is mostly hospital-owned, and then the outpatients are mostly patient-owned. And that's why we've gotten a lot of donations to pay for some of those patient-purchased devices, especially for the blood pressure cuffs.
Is that what you're using for the 30-day readmission program? Is the Apple HealthKit?
No, we actually have a direct integration for that. So the HealthKit, you sign up. So for Withings, Fitbit, HealthKit, you have your own device with that company, your own login with that company. You link that account to us. For the hospital-owned devices, we just have like a serial number attribution. So when you leave, this serial number is now attributed to you. We give you the internet and the scale. For 30 days, that's you. And then after 30 days, it's not you anymore. So it's a key difference between the account for Withings Fitbit based off of our just direct integration with the company.
What platform do you guys use for your 30-day readmission?
So our heart failure one, we're using Blip Care out of Chicago. I don't know why we chose them, but they're really good. Their scale is really nice, and that's just a direct integration. But the Withings, the Fitbit, you got to have your own account with them, and that's why it's kind of separate. That's actually a really good question. I forgot to say that. All right. Thank you. Thanks. And I forgot to say, we do have some open positions.